Hello. Good morning, everybody. Can you hear me? It's 8 o'clock already, and Mr. Tando Nguve is going to lead in the discussion or in the case presentation on initial management of a multiply injured patient. As indicated earlier on, this is going to be a more interactive session, and would like all the trainees to participate, and we'll be asking questions as we go along. Tando, over to you.
Thanks, Hakim. Good morning, everyone.
Morning.
Okay, so I'm going to present on a multiply injured patient. What is my screen doesn't seem to be, okay. All right, so the discussion points for today's meeting would be to look at balance resuscitation, resuscitation endpoints. We're going to discuss massive transfusion, trauma scores, DIC, and the role of anticoagulation therapy. We'll also touch on damage control, orthopedics, and then if time permits, our conversation should also include HIV and trauma, nutrition in critical care, post-traumatic stress disorder, depression, and trauma. So, I mean, the extent at which we are going to look at these discussion points will be guided by the response from the trainees. So I think for maximal benefit, they have to get the answers going. Sorry. Okay, so I'm presenting a 45-year-old male involved in a pedestrian vehicle accident, which transpired at night on the 23rd of February this year. He was brought at casualty at 20 past 11 p.m. The casualty officer's assessment, that patient was noted to be bleeding from the mouth, the ears, and the nose. Chest examination was normal. He was hypotensive with a weak pulse, and he was noted to be pale. His Glasgow Coma scale was 14 on 15. He was hypothermic with a temperature of 35.2, and an open right tib fib fracture was noted, which was actively bleeding. The distal pulses were palpable, and a negative spring test for the pelvis was documented. So the casualty officer's assessment was that of a mild head injury, hypovolemic shock, and open tib fib fracture. So the patient got 2 liters of normal saline first, and then he was cross-meshed, and for transfusion of 3 units. Bloods were taken and x-rays were requested. So the picture shows the state of the leg of that patient. You can see exposed bone, muscles, and it's deformed as well. So when the patient was reviewed at 10 in the morning, that's roughly 10 hours later, he was noted to have received 1 unit of PEG cells. He couldn't open his mouth. He was just mumbling when he tries to speak. There was no obvious feature of the jaw, which was noted. He had reduced air entry on the right side of the chest, basal crepitations on the left side. He was still hypotensive. Glasgow Coma scale was 15. Slight improvement from the 14. Perhaps the effects of alcohol were waning a little bit. His pupils were equally reactive to light. He had a right raccoon eye and clotted blood on the nose and the ears. The abdomen was globally tender with a distended bladder. There was no blood on the external urethral meatus. Pelvis exam was equivocal, and x-rays were not yet done at that point. I think understandably because of the challenges of manpower at the hospital. There's no night staff in the radiography department. So the assessment was that of hypovolemic shock, blunt abdominal and chest trauma, mild head injury with query base of skull fracture, and open tip fib fracture. And so continuation of resuscitation, massive transfusion protocol was initiated, plan to do a pan scan, that is brain, spine, chest, abdomen, and pelvis CT scan, to do a fast, and then follow up on the x-rays. We decided to catheterize the patient and apply a pelvic sheet as well. And the patient, we ordered tranexamic acid and ceftriaxone for the open fracture. We consulted the general surgeons, and the patient was red flagged. We assigned an HMO to make sure that the patient is resuscitated, as well as to continuously keep the entire team up to speed on all developments. At this point, I'll just call randomly any of trainees. Dr. Kwetu, can you tell us what tranexamic acid is and why we administered it for this patient? Do we have Dr. Kwetu? Dr. John Yauzi?
Hello. So tranexamic acid is an antifibrinolytic agent. So it acts by inhibiting a breakdown of fibrin, which stabilizes the clot. So its beneficial effect in trauma patients is that they tend to get some form of hyperfibrinolytic DIC due to the ongoing bleeding. So tranexamic acid would tend to counter that hyperfibrinolytic state in patients who are bleeding and remain hypotensive. So it also helps us in the resuscitation of these patients.
Okay, that's a good answer. Further to that, do you have any literature at hand which supports the use of tranexamic acid?
I can only quote the ATLS 10th edition. That's the one which started recommending the use of tranexamic acid in trauma patients, especially the borderline patients or the unstable patients who are facing a problem of them continuing to bleed. And during their assessment, we see that these patients are now tipping into DIC.
Okay, all right, so that's fine. The ATLS protocol, classic trial which you should look at is the CRASH 2 trial, which had almost 20,000 patients where this tranexamic acid was used. But again, its use is extended for arthroplasty, so there's lots of literature that you can quote. All right, so moving on. I would like a volunteer from the trainees, someone who's going to comment on the x-rays.
Okay, Manyarara, may you please comment on the x-rays?
Okay, good morning all. Okay,
Morning, please.
Okay, the three images, one showing the chest, and the other two showing the lateral views, one showing the distal femur and the proximal tibia and fibula, showing a segmental fracture of the tibia and what appears to be an oblique fracture of the fibula as well. And there appears to be, I cannot very clearly delineate the soft tissues, but there appears to be a back slab on one of the films. Then on the chest X-ray, probably what I can map out. Okay, the X-ray, the technique probably not well centered, not well inspired as well. I cannot clearly map out the trachea, but obvious pathology on the right side. It's, for lack of a better word, there is, you cannot clearly map out the lung markings or the vascular markings on the right side. And the cardiac shadow, the right heart border is not clearly delineated. And,
okay, so Dr. Manyarara, just hold that thought right there. I'm sure you'll agree that the chest X-rays are not well done, and not surprisingly, in a casualty environment, some patients will have an inadequate imaging. What imaging would you like to have in order to get you out of this difficult position where you have to make a diagnosis with an inadequate X-ray?
I'm not too sure about that.
All right, that's fine. Let's go on to Dr. Mseka.
I think we can do a chest CT scan. Hello?
Okay, so you request the chest CT scan. There you are.
Okay. I cannot clearly see the image on the right, but it seems like on the right there is some blood in the chest, and I would make it's a hemothorax.
Okay, well, I had the advantage of seeing the entire images, but that's a normal chest CT scan. This patient did not have a hemothorax or a pneumothorax. Okay, let's just go back slightly. So the other X-rays which the patient had, Dr. Museka, is still on the spot. Can you comment on these X-rays, please?
Okay, we have got an X-ray of the skull on our left, and it looks normal. There is no fracture that I can appreciate. Then on the AP of the pelvis and the lumbar spine.
Dr. Mseka, just look more closely at the mandible. Are the teeth at the same level?
No, they are not.
Okay, so what's happening there?
Yeah, there is a fracture on the left jaw.
Okay, so that's a fracture in the mandible, in keeping with this difficulty to open the mouth. Okay, all right, and then the other X-ray.
Okay, it's an AP of the pelvis, And I can appreciate that there is a fracture of the right cerebellum. There is disruption of there's disruption of the iliopectineal line, and there's also diastasis of the symphysis. The clinical femur looks normal. Then I cannot clearly see on the left. But
okay, Dr. Onseka, we need you to be a bit systematic when you are looking at these x-rays. Don't forget the elephant in the room. One, you talked of an acetabular fracture. I can't quite clearly see it, but however, focusing on the pelvic ring, what are the pertinent things that you are looking at, which is what you are worried about, particularly when you are dealing with a multiply injured patient in casualty? What are the obvious things in addition to that obvious symphysial diastasis? If you keep on looking at the pelvic ring, particularly focusing on the anterior structures, there's still something for you to see. Then if you go posteriorly, I hope you can see my arrow. Oh, you can see there's a white arrow where my arrow is as well. You have to look there as well. What can you see?
I did not see your arrow. Maybe you can.
Okay, there's a white arrow. That's Tando's arrow. Yeah. Yes. What can you see there?
I think there's a fracture also.
All right. Is there Chinganga in the room?
Hello.
Oh yes. Can you please describe what you can see on the pelvic X-ray?
All right. This is an AP X-ray of the pelvis, which is also showing proximal femora and the lumbar region.
Cut the formalities. Just go to the pathology.
Okay. There is diastasis of the symphysis pubis. There is a fracture of the inferior and the superior rami on the left side. There is a diastasis of the SI joint on the right, sacroiliac joint on the right side. And I think there is fracture of the transverse process of L5 on the right side. And I'm not too sure about the sacral fracture. If there is a sacral fracture, sacroalar fracture, I would want more imaging to comment on that.
Okay, well done, Dr. Chinganga. So when spotted, you've got the transverse process fracture of L5. So that would suggest a vertical shear component. And if you look down the inferior part of the right sacroiliac joint and compare it to the left side, you'll see that there's a vertical shear component to the injury. I'd also like you to quantify the amount of symphysial diastasis. Okay, so whenever you comment on the X-ray, just give a rough idea on how much diastasis there is. Okay, all right. So moving on, we've got the CT scan there of the skull showing the mandibular fracture, and then we've got the CT scan of the abdomen. Can I ask Dr. John Kujoka to comment with images, please? Sorry, Caspar Kujoka.
Okay. So these are axial cuts of the abdomen, and I can appreciate that there appears to be a hematoma on the this is left, right. On the right side, which I would assume that probably the patient with a liver laceration.
Okay, so
sorry, Dr. Tando, we do have the
Yep.
privilege of having general surgeons joining this meeting. So I'm not seeing any general surgical registrar, unfortunately, but we do have general surgical colleagues who might help us to clarify things on this CT scan.
Okay, all right. I think that's most welcome. I'm sure they can go ahead with your permission.
Mm-hmm. I saw Mr. KitKat. Sir, if willing, would you like to clarify the CT for us? All right, maybe we could go ahead.
Okay, so the other thing that we note here is the distended stomach. You can see the air fluid level. That's a severely distended stomach, and this hematoma is well contained within the liver. But yeah, I think a radiologist or a general surgeon would be most appropriate to comment. I added these images just to demonstrate that the bladder was intact, and then again showing the right SI joint injury. So joint assessment by Ortho and GenSurg in the later part of the day, the patient was noted not to have an intracranial hemorrhage. We cleared the C-spine. The patient has had a displaced mandible fracture. We ruled out a hemopneumothorax. The liver laceration was to be observed, and there was no hemoperitoneum. The patient had an open book pelvic fracture with right SI joint diastasis, and again the open tip fracture and the ongoing volumic shock. So at this point, let's take a pause and engage the trainees to share their knowledge about trauma scores, how you can prognosticate this patient using trauma scores, and I'll be glad also somebody who can tell us about the assessment of blood requirements in this patient using trauma scores. So perhaps maybe I'll ask Dr. Nyawunzi once more.
So we use trauma scores to try and prognosticate our trauma patients. So the commonly used trauma scores in trauma patients would be the injury severity score, and nowadays the new injury severity score. So we'll be looking at injuries in various systems: head, neck, chest, abdomen, pelvis, and the extremities, and classify these injuries according to their severity from a 0 to a maximum of a 6, of which a 6 would be a critical injury, which is most likely fatal. So we take the highest three scores, then we square each and add them. So the maximum score will be a 75. Then a patient with a score of 6 in 2 systems automatically gets a maximum score of 75. So for patients with injury severity score greater than 40, their risk of mortality increases significantly. Then for patients with injury severity score of 15 or more, and they have an associated chest injury. It also helps us in stratifying these patients either for damage control, orthopedics, or for early total care. Since patients with also high injury severity score do very well with damage control surgery as compared to early total care, which increases their mortality. Then the advantage of using a new injury severity score is that it doesn't clamp up injuries in a system. It also separates injuries in one system. For example, a patient with a blunt lung contusion and a patient with also an associated pneumothorax, this can be classified separately. So it also is better prognostication of trauma patients as compared to the ISS.
Okay, perfect. Well done. Right. So the plan at that point was to apply pelvic X and then debride the tibia and fibula and apply an X-fix as well. Keep the patient NPO and insert a nasogastric tube to decompress that distended stomach, and as well as to transfer the patient to ICU and continue resuscitation. This table just shows the blood parameters during the patient's stay in ICU. So the column on the 29th of February, which is in green, that's when the patient went to theater. So you can see the trends in the hemoglobin. The patient was anemic, and looking at the platelets, also thrombocytopenia. Can I ask Trasen, if she's in the house, to comment on the HB as well as the platelet counts?
All right, good morning, everyone. So commenting on the HB, from the day of admission, we don't have any result, but 2 days after admission, we have noted that the patient had an HB of 6, which is anemic, and with second day, the hemoglobin was coming up, maybe due to the transfusion that was being that was in progress up to day on the second, where the HB was now 10, and the platelet was also decreased on the first day of investigation, which was 38. Which was all these things in keeping with the injury severity of the patient. Before I comment on the massive transfusion protocol, I would just want to, pose a question to you, Dr. Tando. I've noted in the first slides that we initiated the massive transfusion protocol initially before just after examination of the patient, but from the examination, I didn't quite get why we say the patient deserves a massive transfusion protocol, because it is a protocol which is used when you're anticipating more than transfusion of more than 4 units per hour, or transfusion of the total blood volume in 24 hours, or 50% of the blood volume in 3 hours. And I didn't quite get it from the first examination of the patient. Maybe you need to clarify for me how you came up with that decision initially on the first call.
Okay, that's a good question. So previously I said on the previous slide, I said, can you give us scores on how you can predict or anticipate massive transfusion? Unfortunately, there was no taker to mention that. But anyway,
okay,
you can. Oh, Casper, would you like to go ahead?
Yeah.
Okay.
So I think in terms of the massive transfusion protocol, initially there was this classification where they used a minimum of 10 units in 24 hours. But it has been found that most of the patients, some of them actually didn't make it post the 24 hours. So now there are other classification systems that you could use to predict a patient who would probably need more blood transfusion, more picked cells of blood transfusion, and you would initially evoke the massive transfusion protocol even before you have started giving even a single unit. So there are scores that involve laboratory investigations, like the McLaughlin score. This one would take longer because you need other clotting investigations like the APPTs and your INRs. But there's another simpler classification score that you can use, which is known as the ABC, which stands for assessment of blood consumption. This one you can actually use it when your patient comes in, and it has 4 parameters with each scored a mark of 1, and it consists of a patient who comes with a systolic blood pressure of less than 90, a patient who comes with a pulse of greater than 120, and a patient with a penetrating injury. And the last one is I'm forgetting the last one, but if you have 2.
A patient who has received blood in casualty. Okay, so that's the last parameter.
Yes,
so
a patient who
received a unit of blood. He has got ongoing hypotension. Granted, it doesn't have penetrating trauma, but is hypotensive and has got a high pulse. In addition, when you read about the ABC, they do speak about the poor predictive value of it when it comes to assessing patients with pelvic injuries. You can easily miss severe blood loss in patients with pelvic injuries by just focusing on penetrating trauma. So that's how we initiated the massive transfusion protocol, just on the basis of clinical examination. All right. So I think that answers the question. Now, Trasen, will you explain why the patient has got a low platelet count progressive?
Yeah, all right.
In spite of blood, getting blood.
All right. So the patient has got an initial low platelet count because with continued blood loss, or it has been noted that a critical value of platelet and loss of coagulation factors is noted in a patient who will lose about 100 to 150% of his blood loss because of also loss of platelet and clotting factors, as well as in patients who have been receiving crystalloids or colloids, and that will be due to dilutional coagulopathy, as well as in just due to trauma. There is a shift, injury to the endothelium will shift the fluid.
What's the keyword, Doc, which summarizes all this spectrum of pathophysiological changes? Just the key term which encompasses all of that. What do we call it?
Disseminated intravascular coagulopathy.
Absolutely, that's correct. So you can say by day 6, this patient has received 8 PEG cells, 3 FPs, and 2 platelet units, and there's basically not much improvement in the HB as well as the platelets. Can we look at the concept of balanced resuscitation? You did touch on administration of crystalloids, if I heard you very well. Can you just tell us further what this term refers to?
Sorry,
Perhaps
come on.
Dr. Chinganga, can you tell us what balanced resuscitation is? Dr. Matsenga? Do we have Dr. Matsenga?
Hello? Hello?
Yeah. Yes, we can hear you. Go ahead. Can you tell us what balanced resuscitation is?
Okay. I think it has to do with transfusion of blood components in the ratio of 1:1 in terms of pegged cells, fresh frozen plasma, and platelets.
Okay, I think that's more towards the appropriate massive transfusion protocol, where you give the ratio 1:1:1. But further to that, how do you explain administration of crystalloids under this concept of balanced resuscitation?
Okay. So initially we give the 2 liters of crystalloid and monitor the response. But for class 3 and class 4 hemorrhagic shock, we quickly transition to giving blood and blood products.
Okay.
We have Dr. Masenda in the house. She can come in as well. Dr. Masenda?
Hello?
Okay, so
Hello?
yeah, we can hear you. Proceed.
Yes. I was saying that it's a concept whereby we try to minimize aggressive crystalloid administration in order to improve patient survival when it comes to massive transfusion. So we monitor the patient after bolusing them with 1 to 2 liters of ringer's lactate and sort of crystalloids, and we assess if they are responding, if they're transient responders, or if they are minimally or not responding at all. And we can then early transfuse them with blood products, which are balanced with a ratio of 1:1:1.
Okay, that's good. So I like the words that you used, giving him bolus, and then you monitor the patient. But remember, this bolus is the volume shouldn't be too high, because remember, crystalloids, excessive administration will damage the endothelial glycocalyx layer of the capillaries, and therefore it will affect the coagulation. Hence, you should not be liberal with fluid administration. You'd rather have a more conservative use of crystalloids and then urgently administer blood. And plasma is good, it repairs that glycocalyx layer, and it helps with coagulation. Okay. So you did mention that when you give crystalloids, you're going to monitor the response of the patient. So I'm sure you're talking about endpoints of resuscitation. Can you just quickly mention them, the endpoints of resuscitation?
Oh, okay. So we can monitor them using serum lactate levels, and these ones you want to keep them below 2. You can also measure the base excess or base deficit in these patients, and monitor the vital signs and the urine output of the patient.
Thank you for coming back to normal medicine. You mentioned vital signs. I think those are easier to mention and spot on. Can you tell us what the target BP, target pulse, target urine output?
Okay, so for the BP, you want to try to aim to get a systolic blood pressure which is greater than 100 and a diastolic greater than 60. The urine output, you want at least 1 ml per kg per hour. And for the pulse, it should be less than 90 beats per minute.
Okay, that's fine. I guess for the sake of time, I know Dr. Mlalazi would like to comment. Please go ahead, sir.
Morning. Sorry, I wanted to raise the same point that Mr. Marquez had raised. Was it's if you want to be clear, not to forget things, you should be able to classify your things, the physiological endpoints and the biochemical endpoints. So she went on to the biochemical before talking about.
Okay, I think that's a good approach. Classify, and then you won't forget the points. All right, and then this patient has got DIC. Could somebody comment on the role of anticoagulation therapy, administration of clexane in a patient with DIC, or the administration of heparin in a patient with DIC? John Yaunzwe.
I had raised my hand wanting to add a bit on the balanced resuscitation. So we discussed the restrictive use of crystalloids and blood transfusion in proportions approximating whole blood. There's also the third component of balanced resuscitation, which is the permissive hypotension. So people should also reckon that. Then to add a bit more on the endpoints of resuscitation, there's also, we need to monitor the patient's oxygenation status.
For the sake of time, John, for the sake of time, so that we can cover other issues, let's focus on point number 4. I'm sure the other ones we have spoken ad nauseam.
All right, that's fine. So with the patient who is in DIC, so initially we want to address the cause of the DIC. Then, as we have seen in our patients, we have given a tranexamic acid to try and stop the hypofibrinolysis. Then we have transfused the patient to try and boost up their clotting factors. Then when the patient is now out of the DIC, we now get worried about them tipping over into a procoagulant state. So we need to give them prophylaxis for them to not to form excess, to go into thromboembolism. So there are some studies which we're taking a look at beneficial effects of heparin in a patient who is still in DIC. That is for patients who their insulting event is a procoagulant event, but there is also seen to be the risk of them also tipping into continued bleeding. So there has to be a judicious use of heparin. Then low molecular weight heparin has been shown to do very well in these patients in trying to prevent them tipping into procoagulation. But we have to see that our patient is now normal coagulation profile before we start them on Clexane, especially if they were in DIC. Then for patients who have been stable and they haven't been in DIC, maybe you can give them maybe 24 to 48 hours post-injury to make sure that to minimize the risk of bleeding before starting anticoagulation.
Okay, that's a good answer. Caspar Kujoka, if you're going to comment on point number 4, I'll give you the go ahead.
Okay. I also just wanted to end on the role of anticoagulation therapy in patients with DIC. One of the things that has been emphasized is that for patients with DIC, when you want to use anticoagulation, it should rather be used to treat the patient, not the results of the patient. By that meaning that there are some indications where you should use anticoagulation therapy, like a patient who then presents with signs and symptoms of microvascular thrombosis with ischemia, like fingertip cyanosis or necrosis or skin necrosis. Those are the patients that there's an indication for use of anticoagulation. There's also the issue that in the pathophysiology of DIC, there is actually an imbalance with the low antithrombin 3, which is where our unfractionated heparin actually works mainly. So the efficacy of heparin is also sometimes debatable in terms of use in patients with DIC.
Okay, thank you very much. Right, so the patient was taken to theater. He was noted to have scrotal swelling. Pelvic X-fix was applied. Just a tip on the application of pelvic X-fix. You can see the bars there. The bars should face towards the feet, and you leave the abdomen free so that if the general surgeons need to do a laparotomy, the bars are not in the way. Secondly, you should leave adequate space between the bars and the abdomen in case the patient gets abdominal distension, as well as to allow the patient to be able to sit up without obstruction of the hips. We applied a monoplanar X-fix, which is not the ideal one. There was a shortage of hardware. All right, so that's the post X-fix application X-ray. You can see that the symphysial diastasis has been reduced, albeit it's not perfectly. You can see there's a depressed, a displaced superior ramus fracture. We didn't correct that SI joint vertical shear component. Ideally, you should put the patient on a traction table or put a transfemoral Steinman pin since it's got a tibial fracture, and then check down that hemipelvis before closing the book. Yeah, and so that's the tibia there. Now, was damage control orthopedics appropriate in this case, or should you have gone for early total care since this patient was already on day 7? Dr. Muyengwa? Trasen?
Yes, I think damage control was appropriate for this particular patient. Oh, sorry, when did you do the fixation?
The surgery was done on day 6 post-injury.
Okay.
I'll not go into the reasons. It was a combination of logistical issues and many other issues beyond our control.
Okay. So I think, all right, I want to start from the beginning. I've noted the patient has got an open book pelvic fracture, and I think it was also good since we had delays in going to theater, maybe it was prudent to just put a pelvic binder from the word go, and the patient was unstable as well. So it was, I think it was appropriate. Maybe you just didn't mention it. Then on day 6, damage control orthopedics, I think it was the right choice to do because still our patient was still unstable for total care. Looking at the laboratory parameters that we have shown, the patient was still down with some anemia, and the platelet was also still low, and the patient was not yet well resuscitated. So damage control was the appropriate thing to do.
In the ideal world, where you have all the resources, human resources and everything else, what should have been your ideal timing of surgery? When would you have done your damage control intervention?
I would have done the damage control the first day, the first 24 hours after after injury. I would put the X-fix for the pelvis and X-fix for the tibia as well.
Okay, perfect. All right, so the progress of the patient, you can see the wound gradually healing. We never got a chance for the patient to go back to theater. Most patients, you only have theater once. He was discharged from ICU day 2 post-op. Infectious diseases and physician consults were made, and was started on ARVs. That's day 9 after the injury. Uro was consulted for the scrotal swelling, and an impression of a partial urethral injury was made. They advised us to keep the transurethral catheter for 6 weeks. The patient developed severe weight loss, for which we gave him plumpinat and multivitamins. Also complained of insomnia and anxiety, always complaining when will this metalware be removed. He did have pin tract sepsis, for which we gave cloxacillin, and we did pin tract care. So this pelvis X-ray is at 6 weeks after removal of the pins, and then the tibia, you can see evidence of loosening of the shunt pin and some periostal reactions. But again, the fracture is healing. There is a gap there in the distal part. I think we're running out of time. Would like to discuss point number 2. Dr. Kujoka, can you tell us what trickle feeds are? Dr. Kujoka, discussion point number 2. If you can tell us what trickle feeds are.
Okay. I think I might not have met the term trickle, but I think for nutritional care in critical nutrition in critical care patients, we
okay. So trickle. If you just take the word trickle, you're giving maybe feeds in a fluid form, small or minute quantities, 20 mils. So you're giving them just in small boluses, usually per nasogastric tube. So what's the benefit of just giving
for critical care patients, especially trauma patients, the preferred mode of feeding is enteral.
Your sound is poor. Your sound is poor. I think I'm going to ask Dr. Nyaunzwi.
All right, so these patients get increased metabolism as a stress response to the trauma. So getting to feed them early has been shown to help them preserve the body stores, especially preventing protein breakdown, which will be actually essential for their healing and to meet their energy needs. So starting them enteric, especially enteric feeds, has been shown to be very good in trauma patients as compared to parenteral feeds.
Okay, so you prevent gut trophy. Okay, so trickle feeds have got a trophic effect on the enterocytes, prevent atrophy, and remember the gut plays a role in the immune system of the patient. Lots of immunoglobulins come from the gut. In addition, you prevent the buildup of bacteria in the gut, and in a patient who is intubated, you can have a reflux of those bacteria, and you get ventilator-associated pneumonia. So that's the benefit of giving trickle feeds. And then, since we're running out of time, just briefly, how do you approach managing post-traumatic stress disorder? Dr. Museka? Do we still have Dr. Museka?
Yes, sir. We need to engage psychiatrists and also psychologists. We counsel the patient early. Then the patient can be seen by the psychiatrist, and they might need some medication for that. So we also have to involve the family for the patients with the support and for the continued care.
Okay, all right, that's good. So it's a multidisciplinary approach. So just looking at relevant literature for those previous discussion points, there's a high prevalence of post-traumatic stress disorder, depression and anxiety in HIV positive patients. That's studies which were done in Zimbabwe by Chibanda as well as by Vehi. And then the prevalence of HIV in trauma, Sifiane and other authors reported a 23% HIV seroprevalence in orthopedic trauma patients at Joburg Hospital. And then again at the same hospital in general trauma, not restricted to orthopedic patients, the HIV seroprevalence was 27%. And then in a study done in 1994 in Bulawayo by Cohen and Rank, it's a long time ago, this was 16%, and 83% of those patients were asymptomatic. This patient is now, this image was taken at 3 months post-injury. The wound isn't yet fully healed. The proximal tibia fracture is healed, but the patient complains of mobility at that distal fracture where there is the wound. So yeah, at this point, maybe I can get suggestions from senior faculty on the possible way forward in terms of managing this patient. the X-ray, most likely, I don't have a new X-ray, but the distal fracture, there's that gap there.
Is the wound still discharging?
No, it was not discharging.
Okay, that's
It's
fine.
granulated, and that exposed bone is almost completely covered.
Yeah. So you've got okay, you got an advantage that you've got almost 25 or so cortical contact, and you have to define your goals. I'll make my critical goal in this particular case, considering COVID and the resource constraints that we have, to getting your goal has to be getting union, right? So how do we get union easily in this particular case? If you go in on the distal fragment, freshen the edges and probably shorten a bit, taking half a centimeter on each side, and then bone graft from the iliac crest, and then achieve union. Even if it gets a shortening of a centimeter or two, I'm sure you'll be able to tolerate that, and you can put a shoe raise. If you want to go fancy, then but still that particular gap, I'm sure it's still bone graft, and making sure you maintain your tibial height. I think that gap is small enough to be able to be healed by just simple bone graft.
Okay, thank you, Mr. Makeza. So from this case discussion, possible features should be to look at the seroprevalence of HIV in orthopedic patients. The literature which I gave you there is at least 10 to 26 years old. I think we need to re-update and see the current issues challenging us at the moment, as well as to look at the outcomes of polytrauma management in a low resource setting. And then perhaps I'll challenge our well-read trainees to do a literature review and look at that topical issue of the role of anticoagulation therapy in DIC. I will acknowledge the doctors written down there for their contributions towards the management of this patient. And Mr. Mlalazi had his hand up. Please go ahead, sir.
Okay, I wanted to find out clinically how's the pelvis, since you don't have new X-rays, and also on where, according to Mr. Mageza's management, when you shorten, you'll be able to even completely close that wound. And also, yeah, clinically, how is the pelvis? Because I have a concern also on that shortening. Already there's that vertical shift, as noted that you couldn't manage to reduce it. With further shortening again, wouldn't it even make it worse? The affected limb being even more shorter.
Yeah, so for the pelvis, he's not complaining of pain, and we went even further to ask him about sexual function. He's not having any issues in that regard. He's able to weight bear on the left side, pain-free, but on the right, because the tibia hasn't united, is not able to weight bear. If to be able to tell if that SI joint is stable or not, we would actually consider doing single leg stance X-rays to check for instability. But in the setting of this non-union, I think it's not going to be possible. But in my opinion, I think it's doing fine with respect to the pelvis.
Okay.
Outstanding.
Right.
Yeah.
Yeah, but I would keep monitoring it. In the long term, you might get problems because that displacement is huge, I would say.
I agree.
Okay.
Okay, so that does it for my presentation. I'll hand over back to you, Dr. Makeza.
Thank you, Tando, for that impressive presentation. It highlights a lot of things in our settings, the dilemmas that we face in patient management, where ideally you're supposed to do damage control intervention in the first day or second day. You end up having to do that in day 6, and you could not even do the definitive management that you would like to do. So that leaves a lot to be desired, and we can only change that when we jump onto your second last slide on research, because with research you can then tell the powers that be that this is the dilemmas that we face and this is the ideal. So it challenges everybody here to try and think of ways of doing research, albeit in resource limited settings as we are in, but we have to keep on fighting so that we improve the care of our patients. Thank you everybody for attending. We'll meet again on Friday. I'm sure it's Dr. Mdede presenting on something on the knee. Good day, everybody.
Thank you. Bye.
Bye.